Okay, I think we have people joining in and we can start. Welcome to see all of you again. And for our next edition of the AAP section of Neonatal-Perinatal Medicine Journal Club webinar. Today is a very interesting topic, not our typical one, which does not directly involve neonatologists, but certainly affects all of us in what we do every day. And the other reason we chose this topic is just for trainees to realize that, sometimes to make a huge change in the overall health, all it requires is a smart idea, a willing person to do it, and a small intervention. So to do that, we have Dr. Greg Valentine to explain this trial, who started this trial as a fellow, persisted, so a lot of perseverance to learn from him too today, and came with this trial and finally saw it to the finish line. And our co-mentor is Dr. Wally Carlo, who most of you know as known as the pioneer of neonatal global health and probably one of the most prominent person I know who also comes with its very small, simple intervention, which massively improves outcomes and lives of babies all around the world. So with that, I'd like to move towards the introduction. And before that, I'd like to welcome our trainee presenter, Dr. Gretell Zagout from Miami University, for giving this presentation today. With that, Maddie, you want to introduce Dr. Valentine today?
So it's my honor today to introduce Dr. Greg Valentine. He's an associate professor of pediatrics in the Division of Neonatology at the University of Washington in Seattle, Washington, where he also retains adjunct appointments in oral health sciences and mechanical engineering. He's also an adjunct faculty member within the Department of Obstetrics and Gynecology at Baylor College of Medicine. Dr. Valentine's research includes two main areas of focus, the first being the impact of oral health in pregnancy and the relationship with adverse pregnancy outcomes, and the second, studying early nutritional practices of premature newborns. He's the principal investigator of clinical trials in the United States and abroad, and has received funding from the NIH, Thrasher Research Fund, and Gerber Foundation. He's the co-primary author of the Prevention of Prematurity and Xylitol trial that will be discussed today. Welcome, Dr. Valentine.
Thank you.
Okay, with that, it's my pleasure to introduce Dr. Wally Carlo, who's the chair of neonatology and professor of pediatrics at UAB. His main research interest is in neonatal and childhood research performed in developing countries as well as the US. He leads the UAB sites for NIH-funded network, including the Global Network for Women and Children's, as well as the Neonatal Research Network. He has successfully implemented multiple large-scale, multi-center studies in many developing countries that enroll more than over 300,000 babies, which is insane to hear about. And most of them resulted in large and significant reduction in neonatal and perinatal mortality. So his primary focus is on reducing mortality and major morbidities during early childhood in US and developing countries, and is very well funded by the NIH. And he's won numerous awards for this efforts, including the Virginia Apgar Award. So welcome, Dr. Carlo.
Thank you very much, Dr. Jane.
Okay, with that, I'll have Gretell share her slides and start the presentation, please.
Thank you, Dr. Jane. Give me just 1 second. Okay. Can everybody see that?
Yep, looks good.
Yeah. Okay, great.
And
thank you so much.
Just some housekeeping stuff before we start. If you have any questions during the presentation, please put it in the chat and we'll address it at the end of the presentation. Thank you. Sorry, Gretell, you can start.
No, thank you, Dr. Jane. So like they said, my name is Gretell Gomez Zagout. I'm a third-year fellow in the NICU at the University of Miami. And I'm thrilled to be here today to talk to you all about the PPaX trial. So this is a cluster randomized trial of xylitol chewing gum for prevention of preterm birth. We're going to get into some background information about how we got here and what data existed prior to this trial coming together. And then we'll go kind of into the more specifics of cluster randomized controlled trials and the details of how this particular trial was done. And lucky to have Dr. Valentine here with us to help answer all of our questions about it. So let's get started. So a little bit of background on preterm birth, which of course, as neonatologists, we're all quite familiar with. But in terms of worldwide numbers, prematurity is the leading cause of mortality for children under the age of 5 worldwide. And we know that the occurrence and burden of this is experienced disproportionately in low and middle income countries. This data was published in the Lancet in 2023, and it's looking at the estimated national preterm birth rates across the world. The countries that you see in a darker purple, I've named some of them here. These are the countries around the world with the highest amount of preterm births. And specifically, I want to draw your attention here to the country of Malawi, which is where our clinical trial that we're looking at today takes place, also as one of the countries with highest preterm birth rates in the world. Malawi has a preterm birth rate estimated to be about 20%. 75% of those births occur between 34 and 37 weeks, or with a low birth weight of 1,500 grams to about 2,500 grams. There's a lot of different reasons, as we know, causes for preterm birth are multifactorial, but some of the possible contributing factors to this population in Malawi that have been described have been the infectious disease burden in this country, also periodontal disease, which I've bolded here because it's the focus of our study today. Things like chronic anemia and other maternal comorbidities also play a role in this country having a higher preterm birth rate than others in the world. Specifically to highlight periodontal disease in pregnancy, this has been found to be associated with a 2 to 3-fold increased risk in preterm birth and low birth weight. There have been studies back as far as the early 90s looking at these correlations between the two. In 1996, there was a case control study done in the United States. I think it was out of the University of North Carolina, which showed a previously unaccounted for association between preterm birth and periodontal disease. More recently, in 2022, there was a retrospective cohort study done in Taiwan, which showed that women with periodontal disease in the 2 years prior to delivery were more likely to deliver preterm, especially in the age group of 31 to 35-year-old mothers. There's been also some studies looking at whether having additional dental procedures done during pregnancy would affect your rate of preterm birth, whether it would improve it. And there's been conflicting evidence on this. Some of them saying that having these more invasive dental procedures during pregnancy could cause more hematogenous spread of pathogenic bacteria. Others saying that doing treatments for dental caries and root planing might actually be beneficial in pregnancy, but it's conflicting evidence. Why do we think that periodontal disease in pregnancy affects preterm birth? It's because of the inoculation of oral pathobionts resulting in hematogenous spread and ultimately transplacental transmission of these pathogenic bacteria. Once they cross into the placenta, it can lead to an inflammatory cascade and cause things like chorioamnionitis, which could trigger preterm birth. Specifically, we've seen that in cases of periodontal disease, that patients have an increased secretion of inflammatory cytokines. And this has been implicated not just in pregnancy, but also in other inflammatory conditions like rheumatoid arthritis, cancer, chronic lung disease, and other things like this. So there's a lot of background that this is a state of inflammation and which can progress inflammatory conditions that already exist. Currently, the American College of Obstetrics and Gynecology, their data shows that 56% of women do not see a dentist during pregnancy in the United States, and 40% of women that are pregnant have periodontal disease. So the current recommendations from ACOG are that during pregnancy, women regularly have dental visits, and also that they receive treatment for dental caries. Of note, in the ACOG recommendations, they do mention that xylitol gum is often recommended by dentists to help prevent caries. And there's no known harmful effects during pregnancy of xylitol gum, but this specifically has not been studied. So chewing the gum is not a strict ACOG recommendation, but it's kind of mentioned in their footnotes in their committee opinion that it's something that your dentist might recommend, but we don't really have data on.
Gretel, that's a great summary of kind of what was known in the literature at the time. Dr. Valentine, can you kind of help us with any additional kind of knowledge that was known at the time that the study was done and how that kind of contrasts with these recommendations from ACOG here in the US versus worldwide?
Yeah, I appreciate this. And Gretel, wonderful job putting this together so far. It's definitely something that is, it was well explored during, as you mentioned, Steve Offenbacher of the University of North Carolina in 1996 onwards was the sentinel paper that and finder of these studies that are that show that periodontal disease in pregnancy is associated strongly with preterm birth and also preterm low birth weights, less than 2,500 grams. And so there was a decent amount of literature up to that point, including 11 randomized controlled trials, including the motor trial run by Steve Offenbacher at UNC, and then the OPT trial by McAllowitz et al. That were all published in the early to mid 2000s, 2009, 2011, sometime around that time period. And they all basically showed, as you mentioned, Gretel, that dental scaling and root planing were not associated with improved or preventative effects on adverse pregnancy outcomes. They did improve oral health, but they didn't necessarily prevent those adverse pregnancy outcomes. And my research mentor, who actually devised this study, the PPaX trial that we'll get into, had also studied, and it is controversial, that maybe the placenta of the human placenta might have bacterial signatures, and those bacterial signatures that were picked up were most associated with the oral microbiome. And that was what was kind of leading this path of, well, maybe if there's an alternative to dental scaling and planing, which actually increases bacteremia, as Gretel mentioned, and also is pro-inflammatory. Both of those things, bacteremia in pregnancy and pro-inflammation in pregnancy, are in the causal pathway to preterm birth. So maybe if there's an intervention that doesn't do those things, is anti-inflammatory, and actually potentially prevents bacteremia, like a prebiotic or an antimicrobial antibiofilm agent, which xylitol has been shown to do, maybe those things like xylitol could actually prevent preterm birth while improving oral health and overcome those limitations with dental scaling and root planing. The last thing I'll say on that is the other concerns about dental scaling and planing in the literature was that it was mainly done in the second trimester with those studies that I mentioned. And so the concerns were, is this being done too late in pregnancy? The other thing was that it was being done in periodontal disease, or specifically periodontitis. They had to have periodontitis to be enrolled in those studies. And in the spectrum of periodontal disease, periodontitis is considered the more irreversible phase. So maybe if you did something in the earlier phase or an all-comer study or something like that earlier in the progression of the disease, gingivitis phase, something like that, maybe that could actually make a better impact. And then the final thing is something that's not just a one-time treatment, but more habitual effects throughout pregnancy early on could also potentially increase the effect. So those are all the reasons and rationale for the development of this trial.
Great, thank you. I think that sets us up nicely for Dr. Gomez's next slides.
So coming off of exactly what Dr. Valentine was just talking about, xylitol, we'll get into a little bit of the background of this. So it's a naturally occurring 5-carbon polyol. I think that's how you pronounce that. It's a sugar alcohol sweetener. It has prebiotic properties, and it's used really commonly in chewing gums, in lozenges and other oral candies. It's derived mainly from beechwood, but it can also be found naturally in strawberries and cauliflower. The benefits of xylitol have been pretty well studied. There's a lot on this in the dental literature part of the world about its benefits to inhibit the growth of pathogenic bacteria, reducing plaque, and reducing gingival inflammation. And it's thought to work by increasing salivary flow and pH, which will then reduce the number of bacteria, plaque levels, xerostomia, gingival inflammation, and erosion of teeth, which are all kind of the criteria that lead to this periodontitis that eventually is irreversible. So the knowledge gap here that we're addressing more directly is that it's unknown whether this high prevalence of dental disease and preterm birth and low birth weight deliveries in Malawi is causally related or coincident. And also there's no known therapeutic interventions that both treat periodontal disease, during pregnancy and also lead to a decreased occurrence of preterm birth or low birth weight offspring. So the hypothesis for this investigation was that early initiation and habitual use of xylitol containing chewing gum among pregnant participants would decrease the incidence of preterm birth or low birth weight deliveries. The study was designed as a cluster randomized controlled trial. It was open label, 2-arm study, a longitudinal multi-center and matched paired trial. And we'll get into the details of how this was set up in just a second. And also had parallel enrollment. The enrollment dates were from June 2015 to June 2018. But there was also continued data collection up to 3 years follow-up. So that was completed by October 2021. And Dr. Valentine was actually telling us just before we started, this took quite a long time in terms of timeline to even get to the point of enrollment. And so there was a lot of research that went into making sure that the intervention was something that would be culturally well received, that the education was culturally appropriate and relevant to the population here in Malawi. And so it was quite a long time before just the enrollment period, which seems like 3 years is a breeze, but there was a lot on the front end and on the back end of this prior to getting these full results. I don't know if Dr. Valentine, you want to elaborate a little bit on the timeline of how of before and after.
Yeah, I appreciate that. And I think that one of the things that came up is, so I first of all got involved in this as a fellow, a neonatal fellow at Baylor. So this is through Baylor. I'm currently at the University of Washington currently. And I transitioned here as faculty, but my research mentor, Dr. Shirsti Agard, she's the PI of this, and this was her brainchild. But she had also received a Saving Lives at Birth grant through the Gates Foundation and others that really showed that this was an issue. Periodontal disease in Malawi and pregnant individuals in Malawi was a significant issue. About 70 to 80% of pregnant individuals in Malawi in the run-up period had what was found to have metrics of periodontal disease. And in that same time, we also looked at flavors of chewing gum. Would they be willing to chew gum? What about lozenges? What about washes? What was the ability for these people to continue to chew the gum during their pregnancy? Also, the development of cultural adapted messages related to oral health and hygiene and access to dentists, even child spacing and prevention of preterm birth kind of topics. And these actually all went into what became the a better description is not control, but an active comparator group, because they receive these additional education and access to the dentist that the general population may not have otherwise had. And we also found that the best form of education was actually through song and storytelling. And so a lot of these things were, these educational topics were in the waiting room with the women that were just sitting there, and they were actually led with like a song-based kind of educational approach on these various topics. So all of this came up in the preceding run-up period of about 3 years or so. Then the trial occurred for another 3-4 years. And then we had another 3 years afterwards of going back to every register for the 10,069 pregnant people that were enrolled in the study and confirming that the documents that we have and all the data, the primary outcomes, were confirmed with the data registers at all of the sites. And that was something that I personally went through and did. And that took 3 years of going through so many charts. And why I have so many gray hairs these days is probably because of those 3 years of going site to site and going through those things. But it was a wonderful team effort. And I only had a very small part. The team in Malawi was the one that really ran this. And I was just essentially a cheerleader for that. But it was a great long-term effort for all that were involved.
Thank you. So as Dr. Valentine mentioned, there were multiple study sites in Malawi where the study took place. There were 8 urban and rural health centers within a 79-kilometer region where the patients were enrolled from. The inclusion criteria was that they had to be over 18 years old, either a singleton pregnancy at less than 20 weeks gestation or planning a pregnancy within the next 18 months. They had to be willing to agree to dental visits, planning to deliver at a health center, and willing to chew gum, which was our intervention. The exclusion criteria was gestation with multiples. We know that gestation with multiples often leads to low birth weights, so they were excluded. Anyone who had a known or suspected non-viable fetus was also excluded. And then just a note here that periodontal disease was not an excluding factor. Like Dr. Valentine mentioned, some of the previous studies, you had to have periodontitis to be included in those studies, but in this one, that was not a requirement. I did have one question for you, Dr. Valentine, as to, and maybe it was, but I didn't see it mentioned, of why women who had a history of preterm birth weren't excluded from the study, and was that any part of the data that was collected maybe afterward?
Yeah, we wanted it to be an all-comer study for generalizability purposes. And yes, that is always the question about those with a history of preterm birth being, we all know that the individuals with a history of preterm birth are much more likely to have preterm birth in the future, but that's usually like 30 to 40%. In Malawi, there were some estimates of up to 29% of all births were preterm. So it was already a very similar effect size. So we wanted to evaluate for an all-comer study to have the increased generalizability here. But that's an excellent point, and something when we're talking about follow-on studies that we're currently designing is, should we first pursue, especially in the United States, history of preterm birth because of that higher rate of preterm birth. But yes, all-comer study for this one.
Thank you. And then before we jump into the specific methods of this study, we just wanted to briefly review what a cluster randomized controlled trial was. And so different to a standard randomized controlled trial, in a cluster RCT, the randomization is done in clusters or groups instead of at the individual level. So rather than having one person enroll in the study and automatically assigned to one group of the other, you're assigning a large, either sometimes it's a school, in our case a clinic, a specific group of individuals to all receive that same intervention. So your intervention is also applied as a whole group rather than individuals. The pros of doing this type of study is that you're able to capture a large group, and it's logistically a little bit easier because you're assigning, rather than assigning each individual and having to analyze them, you're assigning a whole group. Everyone who's here is getting this, everyone who's here is getting that. And so that part of it makes it a little bit easier. It's also a type of study that prevents contamination, meaning that individuals in one arm of the trial, say the control arm, have been exposed to another arm of the trial, say the intervention, and they know, for example, if it's an obvious intervention that people can see amongst each other, then people who are in the control group versus the intervention group would know automatically. So these are some great benefits of this trial, of why it worked in this type of setting, trying to capture a large percentage of the population in the easiest way possible for this type of intervention. So it was a great design for this type of study and intervention. So just like with any type of research, there's some cons that come with each way that we do these types of studies. So specifically for cluster RCTs, you do need a higher sample size to be able to get appropriate data. You also need to have ethical considerations in mind, especially if you have an intervention that is particularly beneficial for one group of people and you are not giving it to another group of people. And so those are things that need to be accounted for in the design of the study to make sure that ethically it's something appropriate to be doing. The other thing is that the statistical analysis is a little bit more complicated. You have to adjust for confounding variables, specifically because instead of now randomizing an individual, you're randomizing a whole group of people. So what if that whole group of people that you're randomizing to one side or one group has a lot of similarities and they're completely different than your other group? And so those are things that need to be accounted for when you're doing these types of studies. And I don't know, if Dr. Valentine, if you want to expand on that any further, of why this particular setup was chosen for this trial.
Yeah, I think you did a great job. I will say that since we started this study, we did do statistical analyses to evaluate for that intra-class correlation coefficient, the ICC, that you have to adjust for. That's kind of the last part on your last bullet here with the adjusted statistical analyses for the clusters. The issue that is one of the limitations with the study that we'll talk about, which you might get into this later, Gretell, I'm not sure, is we only had 8 clusters. And so that is kind of a smaller cluster design trial. And newer things that have come out in statistical methodologies have suggested minimums of in the teens to 20s of clusters to help offset some of the smaller clusters sizes and design. So that did really develop more like during and after PPaX was done. But that being said, it did help with the contamination, especially giving xylitol chewing gum and making sure that if one person was enrolled in the same household, that they didn't share and whatnot. So we did find that was a really helpful design for what we chose. But
yeah, absolutely. And so let's get into a little bit. Oh, go ahead.
Before you keep going, I'm wondering if Dr. Carlo also has some comments with his global health trial experience and knowledge, because I think we do have a handful of cluster trials, I think, in the last few years in the US, but potentially it seems like maybe this design actually is quite well suited for community-based interventions, et cetera, in sort of other lower middle income countries.
So yes, we did a cluster randomized control trial that was pretty large. We did 2 of them. But the large one was in 7 countries and 96 clusters, and was pretty large, 120,000 patients total in the whole study. One part was not randomized, and the second half was randomized, so about 50,000, 60,000 patients randomized in a cluster randomized control trial. There are pros and cons, but some studies are very difficult to do with individual patient randomization. So I think this one is an example of one that would be much easier to use, especially with the limitations that you have to prevent contamination. If you have a mother getting gum and another not, then they may want to do it also. They hear from their friends. So I think it's a really good design.
All right, so I'm going to move forward and get into more of the specifics of the trial design. So there were 8 Ministry of Health centers that were all well-established maternity care centers. They all had similar resources, and importantly, they were a similar distance from the main referral hospital for preterm and low birth weight infants. And so the way that the centers were paired here were based on the highest number of annual inborn deliveries. So this was data that was collected prior to initiating the study, looking at which centers had the highest amount of inborn deliveries, and the centers were paired based on highest to lowest. So centers 1 and 2 were paired. They were the highest number of inborn deliveries, and 3 and 4 were the next highest, and so on all the way down to centers 7 and 8. And then within each pair, the clinics were randomly assigned to either the xylitol intervention group or the active control group. And so within each pair, you had one group receiving the intervention and one group that was the active control. And the next slide here gives us a little bit more information about these 8 study sites. And I've added some color here just for ease of seeing which ones were paired together. And so you can see here, for example, sites 1 and 2, they were the highest amount of projected annual inborn births. And it shows here in this table really nicely the neighborhood description of the participants, whether they lived in an urban or more rural setting, and what their occupation was as well. And in here, I'd just like to highlight that this is something that we were talking about that has to be accounted for when you do a statistical analysis of a cluster trial, whether there's differences between your groups. And so if you look at, for example, groups 1 and 2, here you had 100% of the population within both groups that was rural. But if you look, for example, at groups 5 and 6, in group 5, you had almost a 50-50 distribution between urban and rural versus group 6, which was their paired group, which was almost 100% rural population. Similarly, when you look at occupation, some of the groups had very similar amounts of different occupations within each group, but some of them had large differences. And so this is something statistically that the investigators accounted for when the statistical analysis was done. But I think this shows a good example of why this happens in these cluster randomized control trials, and something we have to keep in mind. So for our 2 groups, the active control group received prenatal and oral health education. This was delivered primarily by community health workers in each clinic that were a part of the trial. And this education was delivered in an individual and group setting, and also in song form. And I don't have the video for it here, but it is on their website of the PPaX trial. If you want to see what the songs are, there are videos of that on there that you can see. And like we mentioned before, in order to design these educational materials, they had to keep culturally acceptable practices in mind. And specifically when it comes to oral care, because that's what we're focusing on for this study, part of the education tips were brushing twice daily and seeing the dentist during your pregnancy. In the intervention group, they received all the same education, and they also were chewing the xylitol gum. There was about 1 gram of xylitol per piece of chewing gum, and they chewed it for 10 minutes twice daily after morning and evening meals. And the gum was meant to be the last thing consumed in the evening before bed. To expand just a little bit on the education provided to all participants, there were some that were one-on-one education, some that were in group settings in the waiting rooms of the clinics, in oral and song format. And some of the points that were specifically covered in the educational content were things that were risk factors for preterm birth, how to diagnose preterm birth, signs that you are going into preterm labor, details of available interventions that the pregnant participants could expect to happen if they presented to the clinic with these symptoms. They talked about important oral health and prevention of periodontal disease. They talked about reproductive health and contraception. They talked about the spacing of pregnancies in between to try to prevent preterm birth, about the benefits of breastfeeding, proper nutrition, and lots more. They even covered specific things like preeclampsia, intimate partner violence, drug use, lots of things in these booklets. And I have just a few screenshots of some of the pages here of the education that the participants were provided. This is what some of the pages were looked like. They're all very simple, concise, easy to understand, illustrated with photos. And if you want to flip through them, they're a really great resource. They have them all on the PPaX Trial website. The pre-specified outcomes that were planned for the study were co-primary outcomes of a reduction of preterm birth, defined as birth less than 37 weeks gestation, as well as reduction in the rate of low birth weight neonates, defined as birth weight less than 2,500 grams. In addition to that, they did a sub-analysis. They planned to do a sub-analysis of births that were both less than 37 weeks and less than 2,500 grams, as well as looking at secondary outcomes of births less than 34 weeks, over 37 weeks, and then specifically for dental outcomes, looking at the reduction in periodontal disease and dental caries. So here in this flowchart, it's a summary of kind of what we've been talking about with the specific numbers. And so out of your 8 health centers that were randomized, there were 62,000 non-participants. And so these were participants that were either presented to the clinic but were not referred by clinical personnel. They did not meet the study inclusion or exclusion criteria, or they declined for some other reason. Ultimately, you had 4 centers that were in the active control, 4 centers that were in the xylitol intervention group. There were pregnancies that were interrupted in both groups, 42 in the active control group, 89 in the intervention group. There were 20 enrolled pre-pregnant women in the active control group and 5 in the intervention group. There were 137 lost to follow-up in the active control group and 106 in the intervention group. Lost to follow-up was defined as women who did not deliver at the health center or at the referral centers. So they didn't really have outcome data for their delivery and birth or information about their neonate. And so ultimately in the active control group, they had 5,321 participants who had data analyzed for primary outcomes. And then in the intervention group, they had 4,349 participants who had their data analyzed for primary outcomes. And Dr. Valentine, I did have one question here, which was in this section of non-participants. It is a large number of women, who presented to the clinic who ended up not being enrolled in the study. And so do you have any insight of maybe what was going on there and why, a large portion of women maybe didn't agree to join the study, didn't want to, or weren't able to be enrolled?
Yeah, it's more the latter point you just said. We're not able to be enrolled. And I think it's because we We operated this entire grant under like $300,000, which first of all is like crazy. If you were to do something of 10,069 pregnant individuals in the United States, you're talking of $20 million or more, and we did it under 350,000 or something like that. So we had one community health worker stationed at each of the sites, and they were there during business hours, days Monday through Friday for the most part. So if any people came in on the evening shifts and whatnot. And by the way, for those that may not be familiar with global health, people that come in to deliver, it's very, very different than in the United States, where you don't stay in the hospital for 24 hours. You like deliver and you go home all within a few hours, if not 4 to 6 hours at the most. So these just coming into the clinic and leaving and then getting your OB visits done, with one community health worker, that's why it's more of a, not people were declining, but just lack of ability to reach all the people.
Dr. Carlos, since you have done so many of these trials, is it normal to think such a huge amount of population not participating, and what steps you have taken to minimize this so there's no selection bias introduced?
Yeah, so typically what Dr. Valentine described would not lead to a selection bias because it would be during the hours that there was a worker enrolling patients. So usually that's a good way if you cannot enroll 24 hours a day. But even in the US and in high-income country studies, sometimes they cannot enroll 24 hours a day or weekends because it's expensive. So I think it's a practical issue that you have to exclude many patients. And this is an example of when exclusions, systematic exclusion like that, would not lead to bias, really, because it's just an hours of enrollment.
Dr. Valentine, were the centers, would the patients who weren't present when there's like a health worker there, would they still get exposed to the control intervention, like the education? Was that still present and available for people?
Yeah, those were there. The community health workers were the ones that really helped lead those things. So those still occurred kind of during those same time periods that we were polling and whatnot. And in fact, that's when we would recruit a lot of the pregnant individuals. And by the way, 10% of the people were not actually pregnant; they were pre-pregnant. And so, but they actually had just delivered, and we had enrolled them, thinking that they would get pregnant. They said that they were likely to get pregnant in the next year. But all of that occurred during those business hours, during the clinic, kind of the facilitating those cultural songs and education methods. But yes, both groups did receive that. There just wasn't usually in the middle of the night.
The next slide here, before we jump into some of the statistical analysis and results, just the baseline characteristics by study group of the participants in the study. There were more in the active control enrolled prior to conception. Otherwise, there was no statistically significant differences between the intervention and the control group.
Was there a particular, Dr. Valentine, selecting what to show in this table versus, I don't know how much more data was collected on the groups, in terms of thinking about other demographics that could influence the risk of preterm birth to ensure that the two groups are balanced, particularly with the cluster design? I would think about things, and maybe some of these aren't relevant in Malawi, but things like household income might be relevant. And I think it does mention at some point in the trial about previous dental care. But sort of there are lots of other things I think that could contribute. And did you collect more than what you show, or was there limitations that were put on?
Yeah, so there were a few things that affected how we chose what things to come into this table. One was missing data, quite honestly. And so there was some decent missing data in certain areas, such as previous dental history and whatnot, and dental exams. And so some of those things came in. Also, household income is, for the most part, fairly uniform, but not consistent. And so We actually, I'm not sure if you're going to talk about this at all, but we are having a follow-up study right now, which is what I'm the PI of the follow-up study. And we actually are collecting all of that information right now in 1,000 of the children that following up. And it is fairly uniform. We're also including like food insecurity and whatnot, but we didn't have a lot of that during this initial baseline assessment. And I think that also kind of honestly came down to, we had one community health worker following about 3,000 individuals at any given time. But so there was a little bit of a paucity of that data, which impacted some of this.
All right, so we're going to jump into some of the statistical analysis done for this study. As a trainee, this is often the hardest part of interpreting these studies, is figuring out what all of these different terms mean and how to use them appropriately depending on what data you're trying to analyze. So I've highlighted here just 4 different statistical methods that were used in this study, and then hopefully our mentors can elaborate a little bit more on these. So the first one is looking at the ICC, which is something we briefly mentioned already before. So this trial was designed to have 80% power to detect a 33% reduction in preterm birth less than 37 weeks between the 2 groups. And so in order to do this, when you have a cluster RCT, you have to be able to measure the degree of similarity and correlation between your groups. And so in this particular study, they calculated a need for at least 9,360 participants to maintain a minimal intra-cluster correlation of 0.01. And so the ICC measures this degree of similarity within a cluster. It ranges from 0 to 1, and it affects the sample size needed. And so if you have 0, that means that your outcomes within a cluster are independent of each other and that there's no evidence of clustering effects. So your outcomes within a cluster are essentially independent of each other. If you have a minimal ICC, that implies that the variance within the clusters is much greater than the variance between clusters. And then you use this to make sure that your sample size is appropriate. So for this particular study, that was achieved. The total N for the study was 10,026 participants, and the investigators did allow for about a 10% increase in the number of participants. So they initially calculated a need for about 9,300 and allowed for a little bit more, just accounting for people who they knew would be, lost to follow up or not be able to continue the study. And so the ultimate ICC for this study did come out to be 0.01, showing appropriately that it was appropriately powered for this primary outcome. We'll go to the next one. The next unit of analysis for this trial was parent participants, so pregnant participant, and the fact that they gave birth was the unit of analysis. And so we mentioned before, participants who did not deliver at the health center where they enrolled or at the other 2 designated referral centers were considered lost to follow-up and not included. And so with a group-wise analysis with the intention to treat principal, they determined a significant p-value of less than 0.05. And so using the intention to treat principal helps to preserve randomization. It maintains the benefits of randomization by including all the participants in the analysis, regardless of protocol deviations or withdrawals. It also helps to avoid bias in terms of selectively excluding participants who didn't adhere to the treatment or withdrew to the study, because it takes them all into account. And it also provides a more realistic estimate of the treatment effect, since it considers the potential for non-adherence and protocol deviations that can occur in the real world as we look at this data. The next is a generalized linear mixed methods model. And so they use this in 2 different ways. The first way was a binomial distribution or a binary use of this. And this is used when the outcome variable is binary. So successful, failure, yes, no. And this represents the probability of a certain number of successes. And so in this particular study, the binomial distribution was used to look at the association between the primary outcomes of preterm delivery less than 37 weeks and preterm, that should be low birth weight, less than 2,500 grams. And this was also used for the assignment to the study groups. And then the other part of generalized linear mixed methods that was used was random slope and random intercept. And this was used to compare clustering outcomes specifically by sites. So the cluster was considered the random effect and the treatment was considered the fixed effects. And this random slope allows the effect of the predictor variable to vary randomly across different groups. And then the last one I wanted to mention was the McNamara test, which is something that was new to me that I hadn't heard of before. And this was used for the dental outcomes. And so this particular test is used to determine if there's a significant difference in binary outcomes between two related samples. So it's useful for paired nominal data, which is what we were doing for this study. Our paired groups were the xylitol versus just the active control education group. And so this was used to compare the frequency of each outcome between baseline and follow-up times. I don't know if one of the mentors or our editors would like to comment on any of these. No? Okay, so we'll move forward to the results of the study. So the first thing that we'll look at are the pregnancy and neonatal outcomes of the study. And so you can see here that the data is organized by center allocation group, active control, and xylitol groups. And so overall, there was a decrease in all preterm birth deliveries with a significant p-value of 0.049. And overall, there was also a decrease in all low birth weight deliveries, less than 2,500 grams, with a p-value of 0.044. And then more specifically within each section, there was a statistically significant decrease in the deliveries that were 34 to 37 weeks. However, when we looked at 34 weeks, there was no significant decrease in those rates. Similarly, for the low birth weight data, there was a decrease in the lower birth weights and a decrease in the lower birth weights of 1,500 to 2,500 grams. But looking at less than 1,500 grams, there was no difference. And so we can discuss a little bit of why we think there was no difference in the smaller babies and the younger ones, less than 34 weeks. And also, Dr. Valentine, I had a question for you. If you could elaborate a little bit on the differences in the columns here between when you're looking at the data and the p-values of unpaired versus paired. Because as we're looking at it here unpaired, we do see statistically significant p-values, but then when we look at it paired, we don't.
Yeah, that really comes down to what our original statistical analysis plan was, which was an unpaired analysis. We had paired them at the design, but not planned for the analysis to include that paired analyses in our primary statistical plan. So that's why we had initially put in our unpaired findings, and that's what we had presented. But during the scientific review process, peer review process, they had asked us to also then do an additional paired analyses. And since we did both, we decided to include both just for transparency here. But our primary a priori plan of statistical plan was the unpaired measure of association. So that's why you see both presented, quite honestly, is what like kind of came out of the ringer through the peer review process. Technically, you're supposed to go with your a priori design statistical analysis plan, which is why we felt pretty comfortable with. We had done a pairing to begin with, and then we had already accounted for that, and then we were planning to go for it that way. That being said, even with both analyses, and the reason why there is a little bit of a concern about multiple analyses is because then you do multiple comparisons, and that also then has its own statistical issues. But since that was requested by reviewers, that's why it's here. That being said, the 34 weekers to 36 weekers were still statistically significant in both groups and both analyses. And so that kept ringing out true. And I think that the p-value being just at 0.05, kind of even in the unpaired, also shows kind of that why that ICC, that interclass correlation coefficient, is so important in cluster design trials, and that having more clusters could actually help improve that power. But I think that that's also just because we only had 8 clusters that we saw such a significant effect even with those 8 clusters, but it was still just at the 0.05, just under 0.05. I'm not sure, Wally, or anybody else, if you had any other thoughts on those things.
Just a comment that it's quite important to reduce prematurity, even the late preterm, because those are at high risk of mortality. Even in the US, as you know, the data from the US has shown that at this gestational ages, mortality is very increased. In developing countries, it's even more increase in this patient population. So it is an important group to, it's an important observation that it was reduced, that late preterm was reduced.
And on that same topic, Wally, the point estimates, as you can see, are identical here, right? And I think that reducing preterm birth by what 24% and low birth weight by 30% and it's consistent on your analyses. I think that's pretty important, but yeah.
Yeah, it is an important finding, and I don't want to talk about the mortality, but yeah, this is the patient population that is at such a high risk. And also these 30 late preterms it's a large group also. You can see it here. It's a large percentage of the babies.
And just to add a few, this was from the supplemental tables, a few more additional neonatal outcomes that were found to be significant. So feeding problems amongst the infants in the active control group were a little bit higher. Neonatal deaths and stillbirths were actually found to be lower in the intervention group. And just a note here, as you're looking at this table, so miscarriage here in Malawi is considered up to 28 weeks. And then intrauterine death considered over 28 weeks. That's a little bit different than in the United States, where it's 20 weeks is the cutoff for miscarriage. And then macerated stillbirth here signifies a birth where there was no discernible heartbeat at birth. And so if you could elaborate a little bit about maybe why we think neonatal death and stillbirth were also positively affected in the xylitol intervention group. And then feeding, in terms of feeding problems, I'm assuming this was part of the data that you all collected in those 3 years post the study of maybe what you found in those details.
Yeah, feeding problems was fairly subjective. And so it was just simply a subjective assessment by the postnatal nurses and were there any feeding concerns that were documented. So as a neonatologist, I'm a little iffy on that one personally because it's just so subjective. And even in the United States, feeding intolerance, what does that mean, right? But the neonatal death and macerated stillbirths, I think that also has to do a little bit more with, as Wally just kind of insinuated, prematurity in itself and preterm delivery is associated with significant neonatal death. It's the number one contributor. Prematurity is the number one contributor to death of all children under age 5 and even a neurodevelopmental impairment. And so I think that's significantly why you see the change in neonatal death and macerated stillbirths potentially. But I'm not fully certain on stillbirths per se, but I do think that the fact that you'd have not likely a preterm baby versus a term baby might also have impacts on resuscitation and things like that.
Yeah, absolutely. And what are the practices there specifically in Malawi in terms of resuscitation for these preterm births? We know here in the United States, the ages of peri-viability and all of that are changing and a little bit different. So what do they use there as their criteria?
Yeah, 28 weeks and above generally, and usually it's about 1 kilo and above is predominantly when you would resuscitate. Of course, there are certain babies that are under those thresholds I just mentioned, but that's generally the cutoffs that are generally used. And you can do positive pressure ventilation. Most of the community health centers don't necessarily have CPAP. Those are at the tertiary hospitals, which is also why if you have a threatening preterm delivery, you're supposed to be referred to a tertiary hospital to have the delivery because they have those capabilities there.
Thank you for elaborating on that. The next table of outcomes looked at oral health outcomes, which was one of the outcomes we looked at for this study. And just to note, the dental hygienists that were doing these exams were all blinded to the study group. There was 3 of them that did these exams consistently. And so importantly in this study, they noted that there was a difference in gingival bleeding after xylitol intervention, but there was not a significant difference in terms of dental caries. And so I think it's also interesting that in this study, because periodontitis or periodontal disease was not a criteria of exclusion, you had patients that were coming in maybe with a little bit more or a little bit less periodontal disease. And it still seemed like the xylitol intervention helped in terms of these signs of gingival bleeding that can be early signs of periodontitis. And then here's a few more from the supplemental tables, looking at a few more dental outcomes. Looking at teeth decay, for example, they did find a difference in the xylitol intervention group, that they had less teeth decay after the xylitol intervention, and also attachment or loss of teeth was also improved and significantly better in the xylitol intervention group. Of note here, there was a smaller amount of people who actually went through both dental visits. I think it was only about 10% who had both. And so there is a large portion of these participants that their oral health is still unknown for, which is one of the limitations of the study, just in terms of dental outcomes to look at. But from what we do have, it does show that there are some benefits definitely to the xylitol gum in these patients. So moving on to some conclusions from this study. The xylitol intervention group had a 24% reduction in the incidence of preterm birth of 34 to 37 weeks. And they also had a 30% reduction in very low birth weight neonates. Both numbers, I think, are quite significant in such an important outcome. And the intervention group also may be related to a reduction in neonatal demise. There was 22% in the active control group versus only 8% in the intervention group. And Dr. Valentine, you elaborated a little bit about why we thought maybe that was, and in terms of just reducing the preterm birth rate and reducing the very low birth weight neonates, we can probably, I'd assume that it's also going to reduce these rates of neonatal demise. And there was also an improvement in clinical signs of gingival inflammation in the intervention group, which is part of what we were looking at initially in this study, because we don't have any studies that show both an improvement in oral health and also a reduction in preterm birth and low birth weight infants. Are there any other maybe smaller conclusions, Dr. Valentine, that you all found that you'd want to highlight?
I just think that one of the biggest things is how long it takes to do a clinical trial in general, and especially the nuances of conducting a clinical trial in a low resource setting. And but yet how much honestly more feasible sometimes it is. Not saying that we should be focusing on that, but like we did this whole study with like 8 community health workers, and I think that was pretty impressive, just the team and working with the team in Malawi who really put their all into this. And yeah, just a pleasure to work with the team in Malawi.
My question for you, Dr. Valentine, is the data you have on how effective the intervention was at not the primary outcome for your study, but the primary intent of the treatment, which is the periodontal disease, is much more limited because of the lack of follow-up. And I don't know if you had any more details about the actual adherence to the xylitol itself, but the primary outcome, the 30%, 24% reduction in preterm birth, as Dr. Carlo mentioned, that's a huge difference, a really impactful difference from something where the data we have on the impact on gingival inflammation and periodontal disease, it was significant, but I'm no dentist, but it didn't seem like the impact was huge on the dental disease. And we have so many patients we don't know about. Do you think this is something where, like, a small group that gets the intervention, it's that powerful, and that if you had 100% adherence, preterm birth would be reduced even more? Or what do you think about that in terms of the relationship between it?
One of the major limitations to the PPaX trial was that we didn't get dental exams on every single patient. And the fact that we can't really extrapolate just 10% of the patients who had dental exams and those findings. And as you can see, quite honestly, those findings show that we had a very healthy group that did the follow-up of the two. 5% gingival bleeding is pretty much unheard of even in the United States. And so it suggests that those patients that followed up likely were healthier compared to the general population. So I don't know that we can truly extrapolate those findings from that secondary outcome of oral health, which is unfortunate because of exactly what you said. That is the entire premise, is that it improves oral health and therefore it prevents preterm birth. I do think that we are currently in the process of trying to tackle that with other grants and follow-on to explore that, because that is a notable limitation in the mechanistic evaluation and understanding of how this works. But yeah, we did see this effect, and we don't really, I don't think we can make true distinct inferences on that based on just those gingival inflammation metrics with 10% here.
Before we move into our final comments, I'm just going to launch a poll for the audience, and we can see what our audience thinks about this trial. With that, Dr. Carlo, you want to comment on the results of the study? Number needed to treat of 26 to reduce preterm birth with just chewing gum is pretty impressive. And what does it? We'll see what the audience thinks about this trial and its implication to the U.S. population. But what are your thoughts about this adoption worldwide?
Yeah, I think this is a large effect, very large effect, low cost intervention. Obviously, with most interventions like this, before you want to roll them, scale them up, or disseminate the intervention, no, there may be other studies that need to be done and see can this be reproduced, what sort of effect size we get in other studies. It's likely that it will work, but no, can we see it working in other populations? These are rural patients, mostly with low dental care, as Dr. Valentine said. So does this work in a population with better dental care, for example? So I think there's this opens a great opportunity for further research also.
Gretell, you want to finish up your final 2 slides, and then we can move to closing comments?
Absolutely. So just quickly summarizing the strengths of the study, we had a larger sample size than previous RCTs evaluating periodontal disease therapies and pregnancy outcomes. We already talked about the pros of doing a cluster randomized control trial in this setting. It's an easily accessible and very affordable intervention. I didn't include the price here, but it really is cents per piece of gum. And so if this is something that can be replicated and further studied, it's something pretty feasible to be able to do. They did do bias testing for their primary outcomes, and preterm birth 34 to 37 weeks withstood the bias testing, giving us better statistical significance. This was also a study that provided additional prenatal education to all participants. So regardless if they were in their intervention group or not, you had 10,000 women that were receiving additional prenatal education. And so obviously how to measure the success of that is really difficult, but anecdotally, these women were receiving something positive in terms of prenatal education that maybe they wouldn't have received before. And I think it's also a huge strength that despite being in a low resource setting, all the study sites had ultrasound capabilities, and the patients were able to be recruited either during pregnancy or really early in pregnancy to ensure adequate dating, which was obviously really important for this as well. Some of the limitations of the study, which we've all kind of mentioned as we've talked about today, the cons of a cluster randomized control trial, meaning that we had to correct for these biases, which the investigators did do. The large proportion of patients at each center that were excluded from the study for a variety of subjective reasons could pose the question of whether the study participants were truly balanced between the arms, and our statistical analysis does show that they were, but that's something that can be a limitation in cluster RCTs. Only 10% of the participants attended both dental visits to obtain baseline data before and after the intervention, and so oral health in these participants is still largely unknown, and possibly it would give us better statistical significance and data if we did have more. There was also reportedly low adherence to the intervention. Only about 33% of participants self-reported to be fully adherent to the intervention plan. The intervention was not blinded, and so that makes any study vulnerable to the Hawthorne effect. And also we need additional studies in a higher resource setting with individualized randomization and higher rates of adherence before really being able to implement this into clinical practice. And there's a few discussion questions here that I don't know if we have time for. Let me know, Dr. Jane, and I can flip through them.
You can display your questions on the slide and we can take it. So I'm just sharing the results of the poll. Majority still think that the intervention is great and will certainly help, but we surely need to replicate this in the US, even in a specific subpopulation of poor oral health, to generalizable this results in our population. So for me, I think it's pretty impressive to get such a large reduction with such a simple intervention. And Wally has shown with other studies multiple times in the past too that all it takes is a small spark and a lot of hope and perseverance to get there. So hope all the trainees in the audience could get these lessons from our current mentors today, that it can certainly be done and it is possible to improve an overall outcome and neonatal morbidity with a massive effect size if you truly have the will. With that, Dr. Carlo, do you have any closing comments for us?
I think this is an example of like Dr. Valentine did from the fellowship and keep working on it until you finish it. I think it's impressive and it is inspiring for junior people. Take on a big challenge like this. This is a big challenge. Prematurity is the #1 cause of neonatal, but also infant and child mortality. So it's a big deal. So take on the big problems and don't be afraid. Take them on. And there's a lot of work to do. So I encourage you to take on the challenges.
Dr. Valentine, do you have any closing comments for us and for the young trainees in the audience?
Well, first of all, Dr. Gretell, wonderful job presenting this and preparing. So thanks for your hard work on this. And overall, I think that it does take a lot of resiliency, a lot of speed bumps, a lot of hoops and hurdles to go through. And at times you think it's not going to get published, and this actually didn't get accepted to the first journal we submitted it to. And so it just takes a lot of perseverance, but ultimately you can get it done as long as you have a great team. And especially for global health, having a great team on the ground is important. And I am a big proponent for, we are not there to as a hierarchy. We are there as the consultant and really just to help the team on the ground in Malawi. This is their setting, their population, and we are here just to help them get this wonderful trial done. And so grateful for collaborating with the team in Malawi, who really, this is their success. So grateful to be a part of that. So thanks so much, everybody.
Dr. Valentine, before you go, I do know that you recently were awarded a Thrasher grant, congratulations, for a new study also involving xylitol looking at prevention of developmental delay. And so could you give us just a brief on what your team is working on moving forward?
My mentee is actually it's an early career Thrasher. I'm not sure, Sarah Netches, if you can unmute, but she's the one that actually got awarded. I'm the mentor for that study. Sarah, are you able to just comment briefly on your study?
Hi, everybody. Yeah, thank you so much. This has been such a great discussion, great review of the article. Yeah, we are embarking on a study associated with the current trial that's going on, which Greg had mentioned earlier in the discussion, that's collecting some more granular data during the pregnancy surrounding the microbiome and other aspects of pregnancy and dental hygiene and care. And what Greg is helping me, mentoring me through an early career award to look at early developmental outcomes for those, the cohort of babies who have been exposed or not exposed to gestational xylitol. And so looking particularly at those early neurodevelopmental outcomes before age 2, so at 6 months and 18 months after delivery, sort of post-term. So we're very excited and have had an opportunity to train the practitioners looking at capacity building, having community health workers and gold standard examiners performing these neurodevelopmental tests. And so this is an opportunity to both study these tests as well as bring more early developmental testing to this amazing area.
Yeah. And then the only other thing I'll say there is, so Sarah's doing a wonderful job with that. And we also have a thrasher, a full thrasher that's following up 1,000 of the children that were born during the PPaX trial and looking at their ages, at their development at 5 to 8 years of age. So multiple different neurodevelopmental assessments looking at xylitol and Malawi that are currently ongoing. So we're interested to see how that goes.
Seems like xylitol is there should be included in all the fellows' wellness packages. Okay, well, thank you everyone for this wonderful session again. Certainly such an important topic and very well laid out by our fellow trainee, Gretell. Very amazingly explained the journal club, very complicated topics too. I'd like to again thank our mentors, Dr. Carlo and Dr. Valentine, for spending some time with us, taking some moments to teach us. Our next journal club is on May 29 on the ever controversial PDA topic. And we hope to see you all again there. Thank you so much.
Thanks, everybody.
Thank you, everyone.